I think we'll make a start because I think there's quite a lot of material to go through. So welcome everyone to the Lunch and Learn for Lung Cancer and Targeted Lung Health Checks. This is a webinar which Thames Valley Cancer Alliance is carrying out. We all know about lung cancer, but it's always good to know what's happening, what's new. It's a pretty serious illness you're going to hear about. I'm Anand Sashdev. I'm a GP in Bracknell. I'm also the Thames Valley Cancer Lead, Primary Care Lead, and a CR UK GP. If you have any questions, please put them in the chat box. If you have any observations in the chat box, please. We will try and take questions and answers at the end, but certainly if there's a burning question, you can always put your hand up or put it in the chat box and we'll try and answer them as best as we can. I do request that people please put your cameras off and your mics on mute. We've had various interesting noises coming along, which we would like to avoid this time. But thank you all very much for joining. And I'd like to introduce to you Dr. John Park, who's a consultant respiratory physician in Oxford, who's going to tell us a little bit about an update on lung cancer. So over to you, John.
Thanks, Anand. Hello, everybody. Yeah, my name is John Park. I'm one of the chest consultants in Oxford. I was the lung cancer lead. I'm now clinical lead. Thanks, everyone, for coming today. I have had to run to my clinic room, so I'm now on one screen rather than two, which I'm normally on. So I'm going to just open Teams up next to me so I can see the chat in case anyone puts questions or hands up. I'm going to try and go through things quickly because I think the power of this is to be able to answer questions and really just hear what questions you want answered, because I think lung cancer is a very quickly evolving area at the moment, but also quite a grey zone sometimes, which makes it difficult to, sometimes one work out exactly who we should be referring, how worried we should be. Rid of that echo. So I'm going to share my screen, hopefully. And present. So we have a challenge in lung cancer, and this challenge has been there for a while. And I think we have a national lung cancer audit which highlights, and this gives data a bit delayed, but for 2022, and it shows us how we're doing, and we submit data all the time to this. And what we can see is that whilst we are improving, we were at 20% and recovered after COVID to 18%, we still only operate on 18% of non-small cell lung cancer patients. So there are only 18% of patients who reach a low stage and good performance status to allow curative treatment. But even in those patients who have curative disease, we can only give treatment with curative intent in 78%. We're not reaching targets of getting enough systemic anti-cancer therapy in, and our tracking of how we're doing with our metrics of recording stage performance status to base our data on is also not great. So on several areas, we've got to really try and improve so that our patients get a better outcomes for lung cancer, because we know we still lag our European colleagues. These are two graphs showing data you'll be very well aware of, and it simply shows that if you get diagnosed at an earlier stage, then you have a better outcome. And as the stage increases, the outcomes drop dramatically. And so Alan and Kirsty will be showing you data about the targeted lung health check, lung cancer screening, which is doing immense work at improving this, but we still have a challenge, and 75+% of patients are still diagnosed symptomatically and present late. So we've got a lot of work still to do. So what is the problem with lung cancer? Well, I think it's because the symptoms are vague. What are the worrying symptoms? The symptoms of cough, coughing up blood, and hemoptysis. And this is something I'm going to talk a little bit more about, because I think it's probably a soft symptom, an unreliable one. Weight loss, I think, is troubling and particularly flags concerns, rightly so, and general fatigue and not feeling well. And if we contrast that with COPD and smokers, and what are the common COPD symptoms? Well, they're the same, aren't they? And so how do we pick out those patients that are of significant worry? And I think clinical concern comes into that, the cough that's not improving. And the NG12 criteria are those patients who have cough, fatigue, shortness of breath. But also at the top here, and I think these top 2 points are really important, they have chest x-ray findings that suggest lung cancer. And we know that if you've got a chest x-ray suggesting lung cancer, there's a high pickup of lung cancer. And so I think having a low threshold to do a chest x-ray is still very, very important. Yes, the chest x-rays can not show cancer, but equally, if they do, then we are well set up to pull those patients into the system very quickly, and we get abnormal lung cancer chest x-ray reports straight to us. And we will try and contact patients the next day, whether or not anyone's spoken to them. We will potentially call them cold and get them up to the clinic. I just want to dwell a little bit on this unexplained hemoptysis, because we know from presentation that actually this is a low pickup group for us, and patients who have hemoptysis that resolves with antibiotics and stays resolved, and they have a normal chest x-ray, are quite unlikely to have lung cancer. And that maybe suggests that their hemoptysis is explained by infection. And in fact, if we take all hemoptysis patients, the most common cause of hemoptysis is infection with potentially a bit of background bronchiectasis. And so hemoptysis isn't particularly reliable, yet it is equally hard to say, well, if someone's got hemoptysis, would I not want them to come through a lung cancer pathway? I think I would. But we may be moving into a stage where if patients have a normal chest x-ray, the hemoptysis settles, a normal CT is then reassuring, and perhaps we don't need to engage fully in the pathway. And we looked at the patients in that group with normal chest x-ray, settled hemoptysis and a normal CT, and 5 years later, none of them developed lung cancer. So I think there's a group here where as a system, we may have some savings, but I think it's a difficult symptom. And I just put there that diagnosis, the explanation of what unexplained is. And maybe we have to have a bit more confidence that if there's infection and it resolves, well, that was the explanation. I wanted to dwell a little bit on performance status, because this is on the pro forma that comes with the referral, and is actually so important to us and really valuable information that we can get up front from you, our colleagues. And performance status, as you will know, is split into 1 to 4, 4 being you're in bed or chair all the time, 0 being able to carry out normal activities without restriction. But as we get a more elderly population, there's this 2 to 3 grey zone where patients are ambulatory and are able to self-care but can't work, and they're up and out for more than 50% of time out of the day. But actually patients who have some symptoms and are in the chair for more than 50% of the day, that's quite hard, because some elderly patients are a little bit frail, they're at home alone, they don't get out much, and that might not mean we shouldn't be thinking about, if they've got a radically treatable tumour, treating them radically. And so where we can get this information early, it's really important, because if someone's a definite 3 to 4, well, we're not going to start trying to get them through a surgical pathway. But if they're a 2 to 3, then we may need to see what rehab we can get to them early, if we can get them through a curative intent pathway. And so I really value this information on the pro forma, and it's really important. What is this pathway? Well, we work to the National Optimal Lung Cancer Pathway, which is very aspirational. The pro forma brings in the referral, and we take patients straight to CT. And the aim for us is to see patients within 0 to 3 days with a CT scan and request their investigations. The guidance is that it can be face-to-face or phone, and different trusts do things differently. We do move to face-to-face because we've embedded ourselves with our REDS team at our community diagnostic centre. Barks and Bucks use a combination of phone and face-to-face, depending what the CT shows, but we will often see patients on the same day as the CT with lung function and bloods as well. We also automatically now have internal reporting systems that send our CTs or chest x-ray suggested lung cancer direct to us. And so we may have contacted your patients prior to you getting the results and speaking to them, but that's because we want to own them and want to get through them quickly. The suggestions we should be treating patients within 49 days, that really is aspirational. We're trying to condense the front end of this pathway to mean that we get a diagnosis by day 21 to give us plenty of time to treat. Interestingly, guidance out there would suggest that if there's a suggestion of clinical suggestion of lung cancer, we should be empowering you guys in primary care to do the CT, and only if it's abnormal, send it to us. But I think your workload is plenty enough. There's always that problem of incidental findings that we'll talk about later. And for the moment, we have just taken the decision to try and own this and get patients through as quick as we can. Who to refer, we've touched on that earlier, and I think it's difficult because the symptoms are vague. We have vague symptoms pathways, and clearly we have a very low threshold for accepting anyone into our lung cancer pathways. And I'm of the opinion that I'd like to see as many people as possible. I'm a fan of chest x-rays. Chest x-rays aren't necessarily sensitive, but they are still cheap and easy. And if a patient has a cough that's persisting, knowing that there is a cancer and we can get them investigated quickly, or the chest x-ray is normal, we might miss some, but if the clinical concern's still there, then we would always take the referral. But I think if it shows a pneumonia, then we've got an alternative diagnosis. There are differing views out there on the conversion to pickup rate, and saying, oh, the conversion rate is low from referral to cancer diagnosis. But equally, I think we have to have pathways that are open, accessible, and accessible to our whole populations, no matter what their socioeconomic status is, their ethnicity is. We need to be able to see people quickly. And if that means we're picking up earlier stage cancer, then that's good. If it doesn't, then we can fine tune what we're doing. For me, weight loss and fatigue are always a worry in our respiratory population. It's that persistent new cough that doesn't go. I think getting the investigations done is reasonable. As I said, I think hemoptysis is maybe something that we evolve over the next few years. I put down here smoking cessation because it is absolutely critical, and hopefully with new legislation, smoking will become a thing of the past. But all of these touch points are an opportunity to get patients off tobacco, and getting patients off tobacco is going to save so many lives in so many ways. What are our innovations? Well, we're going to talk about the targeted lung cancer screening, targeted lung health checks, and that's how that's improving early stage diagnosis and reversing health inequalities, and it's a game changer for us. But we do have new diagnostic tools where we have ultrasound that we can take within the lung, and thin radial ultrasound probes that we can extend out into the periphery of lungs, identify nodules and tissue that we can then sample in patients who previously would have had to have a CT-guided biopsy, which is higher risk. We see millions of nodules in patients who've been screened for all other reasons, and this is where AI in the future is going to bring us benefit of trying to identify which ones we need to worry about early and which ones we don't. We're in a new age of treatments as well, which is really exciting for us in lung cancer. Curative intent treatments have our surgery with keyhole surgery. We've got stereotactic radiotherapy, which is very targeted radiotherapy and lung sparing, so we can treat patients with even poor lung function or poor performance status in a radically curable way. And we also have microwave ablation, which is where in the CT scanner under general anaesthetic, the clever radiology team can put a probe into the lesion and essentially burn it and kill it. And that's very useful in patient groups who cannot have stereotactic radiotherapy, particularly because of interstitial lung diseases. And as we see interstitial lung disease patients surviving longer, we know they're at high risk of cancer, and we see cancers evolving. Palliative treatments are in the world of chemotherapy, but immunotherapy is the new kid on the block and is really reducing our need, in fact, for interventional bronchoscopy for debulking and stents, because we're seeing better response in the central tumours, particularly the squamous ones. And then we use palliative radiotherapy to treat pain, chest wall pain, symptoms such as hemoptysis. The best is there at the end, and that clearly should be at the top in bold here, and that's our community palliative care teams, who are brilliant and really key in our palliative patients to getting input early and wrapping themselves around the patient, and they're absolutely invaluable to us. And obviously, it doesn't matter about all of this, smoking cessation still comes in as a key. If we're going to be radically treated, then getting tobacco out the way as early as possible is absolute priority. I talked about immunospecific targets, and there are a range. And really, the importance is for us, that means we've got to get good tissue samples to understand what the tumour expresses, and these are bringing much better outcomes. But also with circulating tumour DNA blood tests, we're starting to get those in early in the process because they can pick up some of these. The learning from the new immunotherapies is that they tend to cause autoimmune type side effects, rash being a common one, but more seriously, they can cause pneumonitis, encephalitis, and colitis. So patients with altered psychology, altered cognition, patients with abdominal pain, patients with breathlessness who are on immunotherapies, we worry about these and we treat them aggressively with steroids and stopping the drugs. So I'm very conscious I've whizzed through a lot of things there very, very quickly, but I wanted really to allow plenty of time for questions because I think that's where a lot of the value of learning is, and it's always hard to know where and how to pitch these talks. So thank you very much for listening. I'm going to get out of my presentation mode and stop sharing my screen.
Fantastic, John. Thank you very much. That was a very clear and very succinct presentation highlighting all the challenges and the difficulties, and really, really good. Thanks, John. Thanks very much. And you've obviously got a either very knowledgeable audience or people who have been blown away by a presentation because there aren't any questions at all. So come on, guys. We've got the wonderful John Park here to answer your lung cancer questions. So time to do this. Now, I think one of the things you said, John, right at the beginning is that we ought to be carrying out chest x-rays according to NICE guidance and most guidance, actually. And winter coming up, it's going to be a really key time for the increase in chest x-rays. So a lot of people will be treating infections, but look out for those warning signs. And so it's a right time to pitch this talk. And we've also got the PCN DES, which some of you might know about, which also suggests that lung cancer is something that needs to be focused on and try and make earlier diagnosis to have that stage shift. Any comments from anyone about any of these things at all?
And Anant, I suppose whilst waiting, if anyone wants to ask anything, I think that chest x-ray thing in infection is quite important as well, because in a previous life where I was a pneumonia leader at Reading, one of the things I think is in patients who aren't responding as quickly as you think they might, or in that pulmonary infection setting, that chest x-ray, so that you know there isn't an empyema, there isn't a cavity or an abscess, or there is a pneumonia in fact, and if there is a pneumonia, then that information back to the patient that this is going to take longer to get better, you are going to have symptoms for 6 weeks, maybe 12 weeks, and I think that knowledge up front can stop repeated admissions with, well, I'm still really breathless and I'm still coughing, is that right? It's like, well, you had a pneumonia. And then the follow-up chest x-ray to know that it's cleared and there isn't a cancer driving it. So subtly, I think chest x-rays are actually really valuable in lots of ways, and they're quick and cheap.
Yeah, absolutely right in everything you've said there, John. And I think that answers some of the thoughts that people might be having. There are a couple of quick questions here. One of the questions from Elizabeth Sherwin is, out of interest, what is the sensitivity of chest x-rays in picking up cancer?
Yeah, I haven't got the actual data on that, because when you look, there are lots of ways in which it's been looked at. Some people have used it more in a screening setting, and we know it's not a reliable or robust screening tool. There are groups where you then look back and say, well, we know there's cancer, was it missed on a chest x-ray? And the more you do, the more frightened you are why what can be missed on a chest x-ray. So I think it's clear that if there isn't a cancer on the chest x-ray, it doesn't mean there isn't a cancer. And if your clinical concern is still high, you can either repeat the x-ray or still refer the patient. I think if it shows a cancer, what's really important is and this speaks to Tim's comment next, is that actually that at the moment here and in other trusts as well, that x-ray report is supposed to trigger referral to primary care and to the MDT coordinator. And to us, it triggers an email to our Reds team. And my admin team will ping me a note saying, or ping our team a note saying, there's an X-ray alert. What do you think? We'll have a quick look and we'll request a CT. And they will phone the patient as soon as they get that, if we haven't received a 2-week rate referral already, and say, hi, really sorry to call you out of the blue, but we've had a report. Your X-ray shows something that needs looking into. We'd like to see you tomorrow with a CT scan, lung function and blood test at the diagnostic centre. And we've really developed that in a QI way, because we were worried patients would completely freak. But so the first bit we did was we just got that report into us reliably, but we also then said, look, let's just phone patients and say, if we were to get you to come up, how would you feel about that? Would that be okay? And interestingly, would you like to come in the morning or afternoon? Because we thought, well, get them up in the morning, get everything done. And they said, yeah, that's fine. Of course, it's nice to know someone's on it and someone's doing something. And we'd rather come up in the afternoon, please, because we hate coming to the hospitals in the morning. And so that's why we have an afternoon clinic. We do it at the CDC because we can get bloods and lung function done at the same time. And patients actually don't mind. Now, you guys in primary care are generally on it as well. So it's sometimes hard to know who's got there first, but we're not going to wait. And we can't robustly say we can capture everyone. We can't robustly say that we can do it in all cases. And so that's why we leave both systems in place. But I believe that if an X-ray suggests lung cancer, we're going to see that patient anyway. We need to own it as best quickly as we can, and we need to get into imaging as quickly as possible. So we can either say, yes, we're worried, or also, no, we're not. And, you know, within a few days, someone can leave going, actually, they don't think this is cancer, which is equally as important.
Yeah, thanks for that, John. I mean, I think really the other point to mention is that not all lung cancer cases have an abnormal chest X-ray. We know that around 23% of lung cancers have had a normal chest X-ray. So I think this persistent sort of symptoms and a risk history is really important. And I'm sure, John, your team and others would be quite happy to at least see the patient or discuss the patient if there is a normal chest X-ray, but there are suggestions, alarm symptoms or signs that this could be lung cancer. So I think that 23% is really important, isn't it, John?
It is, but the caveat to that, I would say, is the hemoptysis group, where actually if someone has hemoptysis, when someone has hemoptysis, and it resolves and it's sort of single 1, 2, 3 episodes, gone a week later, we've treated a lower respiratory faction, things have settled. Most of those times, the CT, if the chest X-ray is normal, the CT is normal. I don't think that means we don't do the CT, but it's a very low yield process. And I wonder in the future whether we're using our resources best by getting all those people into expensive secondary care, when actually we may need a parallel pathway that says chest X-ray normal, short episode of hemoptysis now resolved, CT scan normal. We know at 5 years none of those people have lung cancer. So there may be a system saving in that process. That's a sort of an early thought, and I guess what I'm conscious of is that, you know, we might throw up incidentals, so we need to know that they can be sorted very easily. But at the moment, hemoptysis is in the NG12, so we can, you know, we're very happy to own it. It's in a system that's got only a certain amount of money. We need to work out how we do that best. Sorry, by CDC, I do mean the diagnostic centre in Cowley. And yes, you can only tick JR Churchill or Horton, but don't worry about that. Radiology, the radiology admin team are brilliant, and they direct people to where the scan needs to be done and where it can be done quickest and best. So whether they get an appointment with us depends. We have some designated slots every afternoon where we line patients up with a CT, clinic, lung function and bloods. We have 3 of those a day. So anyone above that may not get the scan here. And also if they live near the Horton, they may get the scan at the Horton and then come and see us. So, and we don't mandate that, because radiology is so good at getting people scanned very quickly that we don't want to disrupt their systems.
Thanks, John. Thanks for that. And thanks, Tim, for the question. The other thing on the NG12, which is quite interesting, is thrombocytosis. There's a lot of evidence that thrombocytosis can be a mark of a cancer. So, from a GP point of view, I would be suggesting to all of you, from a quality improvement activity point of view, that this is case finding for especially lung and bowel cancer. So it could be something you all want to maybe consider doing. Really good for your own CPD, really good for CQC audits, really great for the patient because you might actually pick up a cancer that's early. So follow the process. There are lots of pathways available for thrombocytosis. I don't know if anyone's done any thrombocytosis audits in their practice, but I've certainly done one. And in fact, I got my trainee to do one a couple of years ago, and we found one bowel cancer and one referral to lung cancer recently. Haven't got the outcome as yet. So, out of I think about 120 patients, that's a pretty good pickup actually, and hopefully early enough. So thrombocytosis is a really good audit for you to carry out. Um, any other thoughts or questions from anyone before we go on to the targeted lung health check? Gloria, could you put it up, or is it KK put it up, please? Any other comments or thoughts from anyone? Okay, you can please, what, sorry, Madhu suggests, ask, what was the cutoff you used for thrombocytosis? That's a really interesting question, actually, because I don't know, John, do you want to answer that, or shall I answer it in my understanding?
I'll leave that to you.
Okay.
I tend to, I'm at the other end where people say, "Can you see this patient for lung cancer?" My answer is never no.
Okay, all right. So there are plenty of trials and plenty of audits that have suggested that about 410 is probably a good marker, and anything higher could be abnormal. But also lots of studies that have shown that 380 might be a good marker as well. You'll obviously pick up a lot more. You'll be investing a lot more time and energy in those over 380. But I would suggest anything over 400 is probably a good starter to reassess the patient. Obviously, high platelet like that, there's got to be a reason for it. So you need to assess the patient and do the usual checks and tests. Certainly, if they're high risk, things like smoking, weight loss, all of these things, they absolutely need to be looked into in great detail, either referring to the vague symptoms or the non-site specific pathways, or at least carry out further tests like a chest X-ray and a fit test. And it pays a lot of benefit to getting these done. So please have a look. If you have any queries, get back to us. We can try and help you with any audits for thrombocytosis. So I want to come on to targeted lung health check programs and the screening. Now, unfortunately, next slide, please. Uh, the program manager, Kirsty Speech, was supposed to be presenting this today, but unfortunately, for other reasons, she can't be on mic or on camera. But she's here to answer questions, so she will look at the chat box and answer the questions if they're appropriate for her to answer. So, who's offered targeted lung health checks? Well, it's any resident in the area in the area of Thames Valley, aged between 55 and 74, registered with a GP surgery, is an ex-smoker or a current smoker, and hasn't had CT scans in the past 12 months. There is certainly shouldn't be any history of diagnosis of lung cancer, and performance status is really important in that they should be suitable for cancer treatment if diagnosed. So these are the people who will be offered targeted lung health checks. Next slide, please. Oh, by the way, there's a very good YouTube video which actually demonstrates the benefit and the actual sort of use of targeted lung health screening. So once patients are identified, and these patients are identified from the GP database in terms of a coding of smoking, these patients between 54 and 74 are identified as current or ever smokers. A telephone appointment is arranged with these individuals whereby the risk is clarified and scores are apportioned. And at that point, smoking cessation is offered if they're smokers. But these patients with relevant risk factors proceed to face-to-face appointments and a low-dose CT scan carried out. A CT scans are reported on, and the patient is referred on to a cancer pathway if there is any suggestion of cancer at all. Patient has non-cancer incidental findings or requires further investigations. Patient receives a further monitoring scan at 3 or 12 months, or a patient receives the next scheduled screening scan at 24 months until age out of program. So this is the pathway that the targeted lung health check program follows. Next slide, please. So since the beginning of the program and to August 2024, the following cancers have been found by the programs. Now we have these programs happening in Oxfordshire, Buckinghamshire, Swindon, and Oxfordshire have found 9 confirmed cancer cases. That's fantastic. And Buckinghamshire, 3 cases and 1 indeterminate as yet. In Buckinghamshire, certainly one of them was at stage 1 and another one at stage 2. Swindon, the program has been running for much longer, roughly a year and a half to 2 years. 33 cases of cancer have been found at stage 1, 13 stage 2, 17 stage 3, 2 at stage 4, and 4 unstaged. So, you know, this is beginning to show the benefit of the program, which is to find cases at an earlier stage. Okay, so this is now demonstrating the output of this. In addition, these sites have also found cancers in almost all other cancer sites because of the screening that is being carried out by the CT scanning. Next slide, please. So all sites have begun the targeted lung health program, have experienced a high level of incidental findings due to the nature of the scanning. And all sites have actually have a standard operating protocol in place to guide with action for incidental findings that are all agreed with local levels and with primary care as well. Next slide, please. Sorry, go back to the previous slide again. Apologies for that. So the incidental findings we're talking about predominantly are cardiac, so coronary artery calcification, or can be some sort of COPD or emphysema type of lung illness that is found. And the incidental protocols have actually organized how to actually inform the patient by text message or letter, or if it is severe enough, whether it gets referred into secondary care, or whether it ought to be managed by primary care. Now, the benefit of some of these findings is that it actually helps primary care to put them on the register and manage the patient appropriately. So therefore, it becomes a chronic disease management process. So there is a little bit of work which primary care will have to do as a result of this program, but it is very important to understand that actually this is for the benefit of the patients and your registers. Next slide, please. So the Targeted Lung Health Check program is due to change its name to lung cancer screening, falling in line with other screening programs in April 2025. And participants will receive this lung health check. And contacts within the Thames Valley include Kirsty Speech, myself. In Oxfordshire is Nicola Hodges. In Buckinghamshire, it's Usha Balasubramaniam. And in Reading is Kate Rowley. So these are all people you can actually contact for any further information or support you need. Next slide, please. I think that's it, isn't it, really? Any questions on targeted lung health checks or lung cancer screening at all, please? I mean, remember, the whole aim of this program is to find earlier stage diagnoses, which means treatment is amenable and possible, and therefore improves quality of life and mortality at the end of the day. Any thoughts? Mother's written, there was a massive piece of work for Swindon, and we just had 67 letters coming in, and most GPs were unaware. Yeah, I think that's a really good point, actually. And we've been at pains to try and get the providers, the trust and others who are providing this, to make sure that they actually communicate to PCNs and practices where the program is commencing. It goes on websites, it goes on any possible sort of forum it can, to make sure patients are explained as to what is happening. Secondly, we've actually tried to engage with primary care groups to actually make sure that practices are aware of this program as well. So this is a really important point, Madhu. When it is starting in West Berkshire, it's starting in next year in April. We're hoping that West Berkshire will be able to learn from the experience of the other sites as well. Tim has asked, is there a guidance on how to respond to coronary artery calcification? Yes, there is guidance there, and the incidental protocol actually explains that. We've had discussions with cardiologists to try and develop this as well. I think what we'll do is possibly, when something goes live, is make sure that primary care is cited on the incidental findings protocol as well. And you're absolutely right, if they're asymptomatic, this is still about prevention, certainly in CHD. And who actions the abnormal but non-cancer CT findings? Is it the program, or will GPs be asked to follow up an action? Very good question again. This is the protocol that I'm mentioning. So if the findings are severe, then the patients will be referred into secondary care as per the guidance. If it is not severe and or moderate, in some cases, they'll be referred back to the GP with the findings explained. And then you follow the guidance. So, for example, it may be in moderate coronary artery calcification, you may want to code the patient for prevention, and you may want to actually start them on a statin or aspirin or some other modality that benefits the patient. John, you've got your hand up. Sorry, I missed that. John, did you want to say anything?
No, I just thought it might be helpful to comment from a kind of a secondary care point of view and say that certainly locally, this has been a big worry about the incident findings has been a big worry locally and nationally about the screening program. And an immense amount of work's gone into doing a couple of things. One is making sure the scan's so low dose that we don't find things we don't want to find, but also writing operating procedures and internal referrals for lots of follow-up to really try and minimize the amount that comes back into primary care. And it is, you're right, it's the emphysema and the coronary artery calcification and what to do with some of those. We know that they improve outcomes, but the other things such as aneurysms, incidental renal tumours, there are direct internal referral pathways, and a lot of those are directly referred to bronchiectasis services, directly referred to aneurysm follow-up pathways, etc., with tight protocols. And I'm sure Kirsty will be able to pull all of those and make them visible on TVCA websites or wherever, so that people can see them and be reassured that a lot of thought's gone into trying to minimise what needs to happen by even, making sure we ask whether there are symptoms to go with the coronary artery disease and whether that needs a direct referral to cardiology or not. The patients are counselled, and part of the information is all about that we might find other things that are of relevance to your health, because at the end of the day, you're a smoker, so you've probably got other cardiovascular disease. And that is in part of because not everyone gets scanned. There is a risk score that is added to the patient's history and sort of metrics that mean they have to reach a certain risk to then get the CT scan, and part of that risk scoring is to also say we might find incidental findings. What wasn't in the presentation is incredible with this is that previously, if you were in the lowest socioeconomic group, you were most likely to be diagnosed with incurable lung cancer, and if you're in the higher socioeconomic groups, you were most likely to be diagnosed with curable lung cancer. And so far, the NHSE data, as this gets rolled out further and further, is that trend is reversing in the lowest socioeconomic group. So people with lowest socioeconomic status are now most likely to be diagnosed with curable lung cancer. And given that respiratory disease particularly has refractory improvement in outcomes due to health inequalities, it is really a striking finding, and I think a real game changer for our outcomes and survivals. So, and I guess thank you for supporting it, because as a lung cancer physician, seeing people who have incurable lung cancer and now seeing people who've come through the screening program it really is an exciting time that we can, catch people early and get their disease cured, whilst we implement legislation that means tobacco becomes a thing of the past.
Thanks, John, and thanks for that extra information. Very useful. The couple of other things to mention. Kirsty is the sort of manager leading on this, and I'm the clinical lead for the Alliance. So you could actually sort of email us the presentation, which will be circulated after this webinar. We'll have the email details on there. So if you have any questions, please let us know. The other thing to mention about incidental protocol findings is that this first round will probably end up with having the most incidental findings, because don't forget, 2 years later, the same patient will be invited. So the incidental findings protocol will not need to be enacted, because hopefully it won't have changed much for that patient. Obviously, any changes like cancer will be picked up. So hopefully this beginning hump will be where the majority of the extra work or findings will be. So it should ease up as the program becomes business as usual. Tim has asked, is that change in stage of diagnosis because we're diagnosing more lung cancers, or that we're catching cancers we could have diagnosed earlier? John, I think the question relates to this flipping of the incidence here,
Yeah,
staging.
it's not just lead time bias. So the data out of Holland is that it improves lung cancer mortality and all cause mortality. So this is we're not most in the majority. It's not lead time bias, and the average survival of an untreated lung cancer is somewhere between of a middle stage is about 12 months. So equally, there is a short time frame to find these, and so we are not just catching cancers. We are catching cancers we might have diagnosed later, and they would have presented through the emergency department, because 1/3 do, and they don't survive very well. So, we're not. We may be picking up some more, because we are seeing a sort of non-smoking group of cancers, but I guess they wouldn't be screened. So it's not just lead time bias. We are capturing cancers that would have inevitably presented to us at stage 4 disease, either through our clinics or through the front door.
Thanks, John. Madhu's asked a very interesting question. Is there funding for GPs to do this extra work? The unfortunate answer is no, there isn't. What the program is doing is carrying out the screening to find these cancers, but also the incidental findings may actually add to your register and therefore add to your income. But there isn't extra income for this, I'm afraid. Sorry, I don't think there is any area in the whole country who's managed to get any extra funding. We did discuss it with the national team, but it wasn't very successful, understandably, actually, because although the incidental findings are quite high, in some areas, more like 60–70% of coronary artery calcification, this is a captive population with smoking history. So there will be more findings, but it does mean that we're preventing, which actually primary care ought to be doing, preventing cardiovascular deaths and obviously lung deaths as well. So no, there isn't any funding, unfortunately.
There isn't any funding for us to do the incidental finding work either, unfortunately. Yeah. So we're in that same boat as well, and Kirsty may be able to say more, but the funding's for 2 years too. So we're starting to wonder how we sustain the delivery of the whole process. But the improvement in outcomes is just so important.
Yeah, we will share the slides, and in fact, Kirsty said that there were some more slides, but somehow they've been lost. But we will share the slides with everyone. Those people who've accepted to come today will get the slides. Any other questions at all? Any other thoughts? We also particularly want you to suggest to us if there's any other areas that you'd like a lunch and learn on. Please let us know. Email us and let us know. And any other things that we could do, please let us know as well. I would also signpost you to Gateway C, which is a very good online learning, which is commissioned by the NHS. Fantastic modules there on cancer and cancer-related topics. Really good for your CPD and really beneficial in many aspects at all. So please have a look at Gateway C. It'd be great if you could feed back to us anything else you want to. Final chance to ask any questions. Thank you, John. Thanks for your help today and presentation. Really great. Would you mind if you circulated your slides, John, as well? Are you happy for us to circulate your slides, John?
Yeah, very happy.
Thank you very much. Thanks, John. Okay, thanks all. I'll give you 10, 15 minutes back to your life again to have lunch or whatever you do. But thanks for joining again today, and keep well and happy.
Thanks, everyone.
Thanks.